I want to tell you about a patient I'll call Daniel. He was 72. Disciplined. Methodical. The kind of man who never missed a dose of medication in his life. For nearly a decade, he had taken his cholesterol pill every evening at exactly 7:30 p.m. His LDL numbers were excellent. His cardiologist praised him at every visit. His lab reports were textbook perfect. And yet, his plaque was still growing. I remember the day he came into my office holding his imaging results. He didn't look panicked. He looked confused. "Dr. Serrati," he said, "if my cholesterol is controlled, why are my arteries getting worse?" That question is the reason we're having this conversation. Because here's what most people are never told. Lowering cholesterol and stopping arterial damage are not the same thing. For decades, we've been trained to focus on numbers, LDL, HDL, triglycerides. But plaque doesn't grow because a number is elevated. It grows because a biological process is still active. And the process most doctors don't measure is oxidation. Let me explain this simply. Think of normal LDL cholesterol like clean metal. It circulates through your bloodstream without causing harm. But when oxidative stress hits, from inflammation, aging, high blood sugar, smoking history, or metabolic dysfunction, that LDL becomes chemically altered. It becomes oxidized LDL, and oxidized LDL behaves completely differently. It's unstable, reactive, sticky. That's the version that embeds into artery walls. Here's the shocking part. You can have perfect LDL levels and still have high oxidized LDL. They are not the same test. And the oxidized LDL test, called the OXLDL panel, is rarely ordered in routine cardiology visits. Daniel had 11 lipid panels over 9 years. Not once was oxidized LDL measured. And when oxidized LDL enters the arterial wall, your immune system responds. White blood cells called macrophages rush in to clean it up. They engulf the oxidized particles. But when oxidation is ongoing, the macrophages become overwhelmed. They swell, malfunction, and die, turning into what we call foam cells. Foam cells accumulate. They stack. They form the core of plaque. So plaque isn't just cholesterol sitting there. It's dead immune cells filled with oxidized fat. That's why Daniel's plaque kept progressing despite good numbers. The process, the oxidative cascade, had never been interrupted. And this is where most treatment stops short. Statins lower overall LDL production. They reduce quantity. But they do not directly neutralize oxidative stress. They don't measure the rust. They don't stop the transformation. And if oxidation continues, plaque can quietly expand beneath beautifully managed lab reports. So the real question becomes, what actually interrupts the oxidation process? What prevents LDL from turning into its dangerous form in the first place? That answer is not another prescription. And what I'm about to explain next changes how we think about arterial protection entirely. Now I need you to visualize something with me. Because once you understand what's physically happening inside your artery wall, you'll never look at a cholesterol panel the same way again. When oxidized LDL slips beneath the inner lining of your artery, the endothelium, your immune system reacts instantly. It doesn't recognize oxidized LDL as friendly. It sees it as damaged material, a threat. So it sends in macrophages, specialized white blood cells whose job is clean up. Think of them as sanitation workers. They engulf the oxidized cholesterol. They're doing exactly what they were designed to do. They are not the villain in this story. But here's where the tragedy begins. If oxidation continues day after day, year after year, those macrophages keep arriving. They keep eating. And eventually, they become so overloaded with oxidized fat that they can no longer function. They swell. They malfunction. They die in place. At that point, they transform into what we call foam cells. And foam cells don't leave. They accumulate inside the artery wall. Layer upon layer. Like garbage trucks that arrived to clear debris but ended up blocking the highway themselves. This accumulation forms what's known as the necrotic core, the toxic center of an atherosclerotic plaque. It's not just fat. It's cellular debris, inflammatory material, dead immune cells. And here's the part most people never hear. Plaque doesn't kill by existing. It kills by rupturing. Around that necrotic core is a thin fibrous cap, a collagen layer that seals the toxic contents away from your bloodstream. As long as that cap remains thick and stable, you may never experience symptoms. But inside inflamed arteries, specific enzymes called matrix metalloproteinase, MMPs, begin cutting that cap. These enzymes are meant for tissue remodeling. Under normal conditions, they help repair vessel walls. But under chronic inflammation, they go into overdrive. They thin the cap. They weaken it. They turn it fragile. And when that cap ruptures, the necrotic core spills into the bloodstream. Your body reacts immediately by forming a clot. That clot can fully block the artery within seconds. That's a heart attack. That's a stroke. And here's what unsettles me most as a physician. We don't routinely measure MMP activity. We don't measure cap stability directly. We don't measure oxidized LDL in standard practice. We measure numbers. Meanwhile, the biological process underneath can continue unchecked. There's another layer to this that's even more dangerous. Inflammatory activity peaks in the early morning hours, around 4 to 6 a.m. That's also when blood pressure naturally surges. And it's the exact window when plaque rupture risk is highest. Most heart attacks happen in that early morning period. So if plaque stability isn't addressed, if the oxidative process continues, you can go to bed stable and wake up in crisis. That's why simply lowering LDL isn't enough. You must address oxidation, inflammation, foam cell accumulation, cap stability, and there's one natural compound that has been shown to influence all four simultaneously. But before I reveal it, there's another silent failure happening in most adults over 60. It involves something you've been told is protective your entire life, HDL. And what I'm about to explain about HDL is something very few physicians ever discuss. Let's talk about HDL. For decades, you've been told HDL is the good cholesterol. Higher is better. Protective. Reassuring. And technically that's true. But only partially true. What most people, and even many physicians, never explain is why HDL is protective. HDL is not magic on its own. It carries something on its surface. An enzyme called peroxinase 1 or PON1. This enzyme is what gives HDL its protective power. PON1's job is highly specific. It identifies oxidized LDL, the dangerous, rusted version of cholesterol, and neutralizes it before it embeds into the artery wall. Think of HDL as the patrol vehicle. PON1 is the trained officer inside the car. Without PON1 activity, HDL is just circulating present measured, but not actively defending you. Here's the part that should concern anyone over 60, PON1 activity declines with age. Not slightly. Significantly. Research shows meaningful reductions beginning in the early 50s. By the time someone reaches their 70s, PON1 activity can be dramatically reduced compared to earlier decades. So you might have an HDL level of 55 or 60, which looks excellent on paper, but the enzyme that makes HDL protective may be operating at half strength. The patrol car is driving. The officer is asleep. And oxidized LDL keeps slipping through. This explains something I see frequently in my clinical discussions: patients with beautiful HDL numbers and progressive plaque. Because HDL quantity and HDL functionality are not the same. And we almost never test functionality. Now let's layer this into what we discussed earlier. If oxidized LDL is increasing, if macrophages are turning into foam cells, if MMP enzymes are weakening plaque caps, and if HDL's protective enzyme activity is declining, you now have a perfect storm. More oxidative damage, less neutralization, more foam cell formation, greater plaque instability, and this is happening silently. Without symptoms. Without abnormal basic labs. But there's another process failing at the same time. And this one determines blood pressure, arterial flexibility, and early vascular aging. It involves a molecule your body already produces, one that is essential for keeping arteries open and resilient. Nitric oxide. Nitric oxide is produced by the endothelial lining of your arteries through an enzyme called enos. Its signal is simple: relax, dilate. Allow blood flow. In a healthy, younger body, nitric oxide survives long enough to reach the smooth muscle layer of the artery and trigger relaxation. But in a high oxidative environment, something intercepts it. A free radical called superoxide reacts with nitric oxide within milliseconds. They combine to form peroxynitrite, a compound that is not only useless for dilation, but damaging to the endothelium itself. So the nitric oxide message is destroyed before it arrives. The artery stays constricted, blood pressure rises, and endothelial dysfunction begins. This is often the earliest stage of cardiovascular disease. Before plaque. Before major symptoms. Before diagnosis. Most blood pressure medications force the artery to relax chemically. But they do not stop superoxide from destroying nitric oxide. They bypass the problem. They don't correct the oxidative interference. So now you have oxidized LDL forming foam cells sleeping PON1 reducing protection MMP enzymes thinning plaque caps. Superoxide destroying nitric oxide for interlinked processes. And here's the pivotal moment. There is one fruit, and more specifically, compounds within that fruit, that have been studied for their ability to influence all four mechanisms simultaneously. This is not folklore. This is published cardiovascular research. And in the next part, I'm going to show you what that fruit is, and the clinical trial that changed how I view arterial reversal. The fruit is pomegranate. But before you dismiss this as another superfood trend, stay with me. I am not talking about sweet bottled juice. I am not talking about a garnish in a salad. I'm talking about specific compounds inside the whole pomegranate, particularly a class of polyphenols called punicologens. These compounds are found in the highest concentration in the peel and the white inner pith, not the sweet red juice most people eat. And punicologens do something remarkable. First mechanism, they reduce oxidized LDL. Studies show that pomegranate polyphenols significantly decrease oxidative stress markers and directly reduce oxidized LDL levels. This means less rusted cholesterol embedding into artery walls. Second mechanism, they enhance PON1 activity. Clinical research demonstrates that pomegranate consumption can increase peroxygenase 1 activity, in some studies by up to 20%. Remember what we discussed. PON1 is the protective enzyme riding on HDL. When it becomes more active, HDL becomes functional again. The patrol officer wakes up. Oxidized LDL is neutralized before it penetrates the artery wall. Third mechanism, they inhibit MMP enzymes. Punicologens have been shown to blunt matrix metalloproteinase activity, the microscopic scissors thinning plaque caps. When MMP activity decreases, the fibrous cap stabilizes. Plaque becomes less vulnerable to rupture. Fourth mechanism, they protect nitric oxide. Pomegranate polyphenols act as powerful antioxidants that neutralize superoxide radicals, the molecules destroying nitric oxide. When superoxide levels drop, nitric oxide survives longer. Arteries relax more effectively. Endothelial function improves. This is not about forcing the artery open. It's about removing what's blocking the body's natural signal. So we now have one natural compound influencing oxidized LDL PON1 activation plaque cap stability. Nitric oxide preservation that alone would be impressive. But here's where it becomes extraordinary. A clinical trial led by Dr. Michael Avram at the Rambam Medical Center studied patients with significant carotid artery stenosis, measurable plaque buildup in the arteries supplying the brain. Participants consumed pomegranate daily for 1 year. The control group saw plaque progression of approximately 9%. The pomegranate group saw something unexpected. Their carotid intima media thickness, a measurable indicator of plaque, decreased. Not slowed. Not stabilized. Decreased, in some cases by up to 30% over 12 months. Additionally, systolic blood pressure dropped significantly. Now, in cardiovascular medicine, the standard expectation is slowing progression. Reversal is rarely discussed. So when I first read those findings years ago, I was skeptical. But the mechanisms align. Reduce oxidation. Improve HDL functionality. Stabilize plaque. Restore nitric oxide signaling. The biology makes sense. However, and this is critical, most people attempting to use pomegranate for heart health never replicate the conditions of that study. And that's where the mistake happens. Because the way most seniors consume pomegranate can actually undermine the benefit. In Part 5, I'm going to explain the trap, the mistake that turns a potentially protective fruit into a metabolic liability. Now I need you to pause before you add pomegranate juice to your shopping list. Because this is where most well-intentioned people unknowingly sabotage the entire mechanism. The majority of commercially available pomegranate products are not delivering what the research studied. They are delivering sugar. Let me explain. When you buy bottled pomegranate juice from a grocery store, even the brands marketed as pure, several things have already happened. The juice has been pasteurized, heated at high temperatures. The peel and white pith have been removed. The bitter compounds have been reduced for taste. The natural fiber matrix has been eliminated. What remains is primarily fructose-rich liquid. And here's why that matters. Fructose, when consumed in concentrated liquid form, increases oxidative stress. It stimulates insulin release. It contributes to endothelial dysfunction when taken in excess, especially in adults over 60 whose metabolic flexibility is already reduced. In other words, the sweet red juice most people drink is largely the part of the fruit lowest in punicogens and highest in sugar. The compounds shown to reduce oxidized LDL, enhance PON1, and blunt MMP activity are concentrated in the peel and white inner pith, the parts people discard. The bitter parts. The parts that don't taste pleasant. The medicine is in the bitterness. When the fruit is processed for taste and shelf stability, the therapeutic profile changes dramatically. I've had patients proudly tell me they were drinking 8 ounces of pomegranate juice every morning for their heart. Then their fasting blood sugar rose. Their triglycerides crept upward. Their endothelial markers didn't improve. And they were confused. Because they believed they were following cardiovascular research. But the research did not use sweet commercial juice stripped of its polyphenol density. Now here's an additional layer most people never hear about. One of the primary antioxidant compounds in pomegranate is ellagic acid. But ellagic acid alone is not the final active molecule. Your gut bacteria must convert it into a metabolite called urolithin A. Urolithin A has been studied for its ability to trigger mitophagy, a cellular cleanup process that removes dysfunctional mitochondria. Healthy mitochondria mean less oxidative stress. Less oxidative stress means less LDL oxidation. But here's the complication. Not everyone produces urolithin A efficiently. Research suggests only about 40% of individuals convert ellagic acid into meaningful levels of urolithin A, depending on their microbiome composition. If someone has had multiple antibiotic courses, low fiber intake, or chronic gut imbalance, that conversion may be impaired. So two people can consume the same fruit and experience completely different vascular outcomes. This is why simply adding pomegranate isn't enough. It must be delivered properly. The full spectrum compounds must be preserved. Sugar must be minimized. And the microbiome must be supported. Otherwise, you may be increasing oxidative load while believing you are reducing it. And that's the mistake I never want my patients making. In the final part, I'm going to show you how to actually implement this correctly, safely, strategically, and in coordination with your physician. Now let's talk about execution. Because understanding the science means nothing if the delivery is wrong. And when it comes to pomegranate and arterial health, delivery is everything. There are 2 responsible ways to approach this. 1. The whole fruit method done properly. If you choose fresh pomegranate, the key principle is simple: do not throw away the medicine. That means keeping some of the white inner pith along with the seeds. Yes, it's bitter. Yes, it changes the flavor. That bitterness is exactly where punicogens are concentrated. A practical approach: remove the seeds. Keep a portion of the white pith, not the entire peel, but some inner membrane. Blend with water. Do not strain it. You are not making juice. You are making a polyphenol suspension. If it tastes sweet and smooth, the therapeutic density is low. If it tastes slightly astringent and earthy, you're closer to what was used in research. However, whole fruit varies in potency depending on ripeness, soil, and variety. That inconsistency is something I always explain to patients. Which brings us to the second option. To standardized whole fruit extract for consistent dosing. A standardized extract that includes peel, pith, and seed compounds is often more reliable. Look for whole fruit extract, standardized punicogen or ellagic acid content, no added sugars, capsule form, not sweetened liquid. This eliminates fructose spikes and ensures therapeutic polyphenol density. Now, extremely important, if you are on blood thinners or antiplatelet medication, discuss this with your physician first. Pomegranate has mild antiplatelet properties. It's not dramatic, but it is clinically relevant. This is not a replacement for medication. This is not a reason to stop statins or blood pressure drugs. This is about addressing oxidation alongside conventional care, not instead of it. The overlooked piece, your microbiome. If ellagic acid must be converted into urolithina, your gut bacteria matter. Support conversion with fermented foods, plain yogurt, kefir, sauerkraut. Diverse fiber intake, minimizing unnecessary antibiotic exposure without microbial conversion. Part of the benefit is reduced. Cardiovascular health is not separate from gut health. They are metabolically intertwined. What to ask your doctor at your next appointment? Consider discussing oxidized LDL testing, OX-LDL, carotid intima media thickness imaging, advanced inflammatory markers, because numbers alone do not reflect oxidative burden. Let me leave you with this. Lowering cholesterol is managing supply. Reducing oxidation is stopping damage. Stabilizing plaque is preventing rupture. Supporting nitric oxide is restoring function. When those four things happen together, arteries change. Not overnight. Not magically. But measurably. And that's the difference between watching numbers and improving biology. If this explanation helped you understand what might actually be happening beneath good lab results, share it with someone who needs a deeper conversation about heart health.